Okay, welcome to the deep dive. Today, we are plunging into a topic that impacts how we see the world quite literally. We're talking about squint, or strabismus, a condition where the eyes don't quite line up.
Yeah, exactly. And for this deep dive, we've got a really fascinating stack of source material. It's mainly excerpts from a medical text, giving us a super detailed look at one specific type, comitant strabismus.
Right. So our mission today, to really unpack what this condition is, why it happens, how the experts actually figure out what's going on, and the different ways it can be managed.
Think of it as your shortcut to getting a really solid grasp on eye misalignment, understanding the core ideas that professionals work with. We're aiming for that deep professional level understanding here.
Absolutely. Ready. Okay, let's unpack this. So let's start right at the beginning. What exactly is a squint or strabismus? What are we actually talking about?
At its core, strabismus is, well, it's when the visual axes of your two eyes aren't both pointed at the same thing at the same time. So if you're looking at an object,
One eye's on target, the other isn't.
exactly. One eye is fixed, but the other one might be turned inwards, outwards, up or down. They're just, misaligned.
Got it. Now, the source material immediately breaks this down into two main categories, which seems pretty fundamental. Comitant and incomitant. What's the basic difference there?
Yeah, this is a really key distinction. In comitant squint, the misalignment is there, sure, but the angle, the amount of misalignment, it stays pretty much the same no matter which way you look.
Ah, so if it's turned in by, say, 10 degrees looking straight, it's still about 10 degrees looking up or sideways.
That's the idea, yeah. The angle of the deviation is consistent or comitant across all directions of gaze. The source notes that the problem here isn't usually with the eye muscles themselves or the nerves directly controlling them. Their mechanics are fine.
So it's higher up.
It's generally thought to be higher up, yes. Either something to do with how the brain processed visual input during early development, or maybe a breakdown in the brain's fusion mechanism, that reflex that keeps the eyes locked together.
Okay. And incomitant is the flip side. The angle does change.
Precisely. With incomitant squint, the magnitude of the misalignment varies, sometimes quite dramatically depending on which way you're looking.
And the cause there is different.
Right. The source tells us this type is typically caused by a more direct problem with the final motor pathways, the muscles or their nerve supply. Maybe a muscle is weak or paralyzed. That's a paralytic squint.
Or something's physically blocking it.
Exactly. Or there could be something physically restricting the eye's movement, like a tight muscle from scarring, or even a mass. That's a restrictive squint.
Okay, so comitant is more like a central control or developmental issue affecting alignment, while incomitant is more of a mechanical or nerve problem affecting the actual movement.
That's a good way to frame it. And the source points out some clinical clues, like incomitant squints are more likely to cause double vision, diplopia, and you might actually see restricted eye movements.
Whereas comitant, especially long-standing ones.
They usually don't cause double vision because the brain adapts. We'll definitely get into how it does that. And the eye movements themselves are typically full.
Okay, that helps draw the line. Now, this deep dive is focusing on the comitant type, based on our source. And the text starts by saying the fundamental cause is, quote, unknown despite theories. That feels a bit anticlimactic.
It can seem that way, yeah.
Mhm.
But the text quickly pivots to what we do know. While the ultimate single root cause might be elusive, the source details several really well-established contributory factors.
Ah, okay, so things that make it happen even if they aren't the only cause.
Exactly. Things that contribute or make it more likely. And understanding these is absolutely essential for figuring out treatment.
Okay, let's dig into those factors. What are the key ones the source highlights?
Well, one major player is defective vision, especially if it happens very early in life. If one eye just doesn't get a clear image from birth or early childhood.
Like needing glasses but not having them? Or a cataract?
Right. Things like a high refractive error that isn't corrected, or opacities like a cataract. If the brain doesn't receive good quality input from that eye, it might not develop the strong neural connections needed for binocular vision, for using both eyes together smoothly.
So the fusion mechanism just doesn't get built properly.
Pretty much. If the raw materials, the visual signals, are faulty from one eye, the brain struggles to build that sophisticated system for binocularity. Fusion becomes difficult or impossible, and that eye might lose fixation and start to drift.
Interesting. What else?
Another factor can be subtle issues with the eye muscles themselves. Maybe, congenital things like a muscle not attaching in quite the right place, or maybe not developing as fully as it should.
Creating a tendency to drift.
Yeah, exactly. This can create a tendency for the eyes to misalign, what we call a heterophoria or latent squint, which fusion usually corrects. But sometimes if that tendency is strong or fusion is weak or something triggers it, that tendency can become a manifest visible squint.
And there's a third one, right? Something about focusing and convergence.
Yes, this is a really critical concept, highlighted in the source, often linked back to Donders. It's all about the close relationship between accommodation.
That's the eye focusing.
Right, when the lens inside your eye changes shape to focus, especially up close. And convergence.
When the eyes turn inwards.
Exactly. When you accommodate, it automatically stimulates your eyes to converge. They're neurologically linked.
Okay, so if you're farsighted, hypermetropic, you have to accommodate all the time, even for distance, just to see clearly.
Right. And that constant accommodative effort overstimulates the convergent system. The source explains that someone who's significantly farsighted is constantly asking their brain to focus and turn the eyes in.
But if they turn in too much when looking straight ahead, they'd see double.
Precisely. So the brain faces a choice: blurry single vision or clear double vision. Or a third option.
Just let one eye turn in and ignore its image.
You got it. The brain often chooses clear single vision by allowing one eye to turn inwards, a convergent squint or esotropia, and then it learns to suppress the image from that eye. Clear vision trumps binocularity in that scenario.
And for nearsighted people, myopes, is it the opposite logic?
Generally, yes, though the source adds a caveat that it's not an invariable rule, but myopes often don't need to accommodate as much, particularly for near work. Less accommodation means less stimulation for convergence.
Leading to a tendency to drift outward.
Exactly. This can contribute to a tendency for the eyes to drift outwards, potentially leading to a divergent squint, or exotropia.
So, just to nail this down, if your fusion mechanism is strong enough to overcome these tendencies, the tendency to drift inwards or outwards and keep the eyes aligned, what's that called again?
That's heterophoria. It's a latent or hidden squint. The deviation is only there when you break fusion, like by covering an eye.
And if the tendency is too strong or fusion breaks down and the deviation is visible,
that's heterotropia, the manifest or obvious squint. And the source mentions that comitant squints, whether latent or manifest, can be constant, meaning present all the time, or intermittent, only appearing sometimes. And they can be convergent or divergent.
Okay, let's dive into the manifest types then, the heterotropias. Convergent strabismus or esotropia first.
Right. The source describes this as the more common type, especially in Caucasians, and often linked to that hypermetropia and the accommodation convergence link we just discussed. It always starts in childhood.
Can anything trigger it?
The text mentions it might appear after certain illnesses. These probably act as triggers, pushing an underlying tendency over the edge into a manifest squint.
And does the size of the inward turn change over time?
Yes, often it does. The source notes the deviation frequently lessens as the child gets older. This is partly because the need for accommodation naturally decreases with age. It's usually mainly horizontal, but sometimes there's a small vertical component too.
Okay. What about the opposite, a divergent strabismus, exotropia?
This is more common in myopes, as we touched on, and tends to start a bit later. Not always strictly in childhood. It can even start in late adulthood.
How so?
Well, the source gives an example. If an adult loses vision significantly in one eye, maybe from a cataract or retinal issue, they'll naturally rely on the good eye for fixation. The eye with poor vision, no longer needed for central vision, might then drift outwards to its natural divergent resting position.
And does exotropia tend to get better on its own, like esotropia sometimes can?
The source says spontaneous improvement is rare here. It generally tends to worsen over time if it's left untreated.
Okay, so what does someone with a manifest comitant squint actually experience? The source says, apart from the cosmetic look and maybe losing 3D vision, it's often asymptomatic, which still feels weird. Why no double vision?
Yeah, this is one of the most fascinating and crucial points in the source material. It explains why it's asymptomatic in terms of things like pain or double vision. Diplopia, seeing double, can happen initially.
Especially if it comes on suddenly.
Right, if it appears acutely, or maybe intermittently, in an older child who can actually notice and report it. But, and this is key in young children, where comitant squints usually start, any initial double vision typically disappears very rapidly.
Because the brain actively suppresses it.
Exactly. The brain just finds persistent double vision intolerable. It's confusing. So to cope, It actively suppresses the image coming from the deviating, squinting eye. It essentially learns to ignore that visual input.
It's like hitting the mute button on one eye.
That's a good way to put it. And the source emphasizes this isn't just passive fading, it's an active psychological inhibition. This happens even if both eyes have the potential for good vision. The brain sacrifices binocular input for comfortable single vision,
So no double vision, but at a cost.
a potentially significant cost. While suppression solves the immediate problem of diplopia, if it goes on for too long during that critical period of visual development.
It leads to amblyopia.
Exactly. Amblyopia, the so-called lazy eye. The source defines it really clearly. It's a developmental defect in the visual processing pathways in the brain. It results in subnormal vision, usually measured as at least 2 lines worse on the eye chart than normal or the other eye, without any underlying structural problem in the eye itself.
So the eye hardware's fine. It's the brain's software or wiring for that eye that's underdeveloped.
That's a perfect analogy. And the absolutely critical point is that amblyopia is reversible with timely treatment, but only if it's caught early enough.
What kind of things cause this? What are the risk factors?
The source lists the main culprits, the amblyopia factors. Anything causing a persistently blurred image on the retina early on, like significant uncorrected refractive error or cloudiness like a cataract that's stimulus deprivation.
And the squint itself.
Yes, strabismus is a major cause. The constant suppression needed to avoid the double vision and confusion prevents the visual pathways for that eye from maturing properly. Also, a large difference in prescription between the two eyes, anisometropia is a big one. The brain just favors the clearer image.
And this is all tied to that developmental window.
Crucially, yes. The source really highlights the critical or sensitive period for visual development. It's roughly from birth up to about age 8, but the first 3 years are the most vulnerable. Amblyopia develops during this period.
So if you develop a squint or cataract as an adult, you don't get amblyopia.
Correct, because the brain's visual pathways are already fully developed and mature. You might get double vision from a new squint, but the underlying visual potential of the eye remains intact. Fix the cataract, and vision returns. But in a young child, if the problem isn't fixed during that sensitive period, the potential for good vision in that eye can be permanently limited.
Wow, that really underscores the importance of early detection. The source also describes specific ways the vision itself is affected in an amblyopic eye, beyond just being blurry.
It does. These are important diagnostic clues. A classic one is the crowding phenomenon. An amblyopic eye might be able to see a single letter okay, but struggles to read letters when they're presented in a row, like on a standard eye chart.
Like the letters get jumbled?
Kind of. It's like the brain has trouble isolating or separating objects that are close together. Other things mentioned are vision not dropping as much when viewed through a neutral gray filter compared to a normal eye, decreased ability to pick out fine detail or contrast, issues with judging spatial location accurately. Even eye movements like pursuit can be impaired.
So going back to suppression, you mentioned it mainly affects the central vision, the foreview eye. Does the brain sometimes start using a different spot in the squinting eye?
Yes, this is another fascinating adaptation, especially in long-standing squints. Because the brain is suppressing the input from the fovea, the area of sharpest vision, of the deviating eye when both eyes are open, it might actually develop a new preferred point of fixation in the periphery of that eye's retina. This is called eccentric fixation.
So it creates a sort of false center.
Exactly, a false macula. And along with this, the brain develops a whole corresponding system of abnormal retinal correspondence, ARC. It learns to mentally match up the image from this eccentric point in the squinting eye with the image from the fovea of the good eye, creating a sort of workable, albeit flawed, binocular perception.
Wow. The brain is literally rewriting its visual map.
It really is. It's an incredible example of neuroplasticity, trying to make sense of misaligned input. But the source notes this abnormal system, this ARC, usually only operates when both eyes are open.
What happens if you cover the good eye?
Often, the squinting eye will then revert to using its true fovea for fixation when it's forced to see alone. However, in cases with very deep-seated, long-standing eccentric fixation, the eye might continue to fixate with that peripheral false macula even when the good eye is covered.
And that gives clinicians a diagnostic clue, right? If they cover the good eye and the squinting eye doesn't move to pick up fixation or moves very little.
Precisely. That's a key clinical sign. Observing the deviating eye's behavior when the fixing eye is covered is crucial for detecting eccentric fixation. And the source adds an important practical point. If you surgically straighten eyes that have established ARC, The patient might initially experience double vision because the brain is still wired for the old, misaligned position. Addressing this before surgery is important.
Okay, this is complex. How do the experts actually investigate all this? How do they piece together the puzzle in a specific patient?
The source outlines a really systematic approach. It always starts with taking a careful history.
Asking things like when it started, is it always there?
Exactly. Onset, duration, frequency, constant or intermittent, any previous treatment, any family history of squints, and importantly, what the patient's or parent's goals are for treatment.
And then the examination itself.
First steps are checking visual acuity in each eye separately and observing the monocular fixation pattern, how each eye takes up fixation when the other is covered. Then a general eye exam, including looking at the fundus, the back of the eye.
And you mentioned something crucial for kids, cycloplegia.
Yes, mandatory in children with squint, according to the source. Refraction under cycloplegia. These are the eye drops, like atropine or cyclopentolate, that temporarily paralyze the focusing muscle accommodation and dilate the pupil.
Why is that so important in children?
Because kids have such powerful accommodation, they can easily mask their true refractive error, especially hypermetropia. Paralyzing that muscle allows the examiner to get an accurate measurement, usually with retinoscopy. The source emphasizes really relying on this objective retinoscopy result in children.
And checking the fundus again after dilation.
Absolutely vital. The source specifically mentions ruling out serious underlying causes of squint, like retinoblastoma, a type of eye cancer, or other anomalies. You have to look inside.
Okay. What else are they looking for during the exam?
They look for any abnormal head posture. Does the child tilt or turn their head to see better? They test the ocular movements in all directions of gaze, and then they need to nail down the details of the deviation itself.
Like direction, size, frequency.
Exactly. Direction in, out, up, down, frequency, constant, intermittent, magnitude, the angle, whether it's comitant or incomitant, laterality, is it always the same eye or does it alternate, and measuring the ACA ratio, that accommodation convergence link. Plus, tests for binocularity, can the eyes work together at all?
How do they start estimating the deviation? The source mentions distinguishing real from apparent squint first.
Right, especially important in infants and toddlers. Sometimes facial features, like a wide, flat nasal bridge or prominent epicanthal folds, skin folds at the inner corner, can mimic the appearance of a convergent squint. It looks like the eyes are turned in, but they're actually straight. That's a pseudo-squint.
Doesn't need treatment then, so how do you tell if it's real?
A quick screening test is the Bruckner test. You shine an ophthalmoscope light into both eyes at the same time in dim light and compare the red reflexes from the fundus. If the eyes are aligned, orthotropic, the reflexes should look pretty equal in brightness and color.
And if there's a squint?
The reflex in the deviating eye usually looks brighter, lighter, maybe more reddish yellow, or even white compared to the fixing eye. The brightness difference is the key indicator. It's great for spotting small angles or checking infants.
Neat trick. But the source calls the cover test the cornerstone.
It absolutely is. The cover test is the fundamental way to definitively establish if a true deviation exists and to determine its characteristics. Is it latent or manifest? Intermittent or constant? Unilateral or alternating? Convergent or divergent? Comitant or incomitant? It tells you so much.
Okay, walk us through the different parts of the cover test again. It seems crucial.
Sure. Imagine the patient is looking steadily at a target. First, the basic cover test. You quickly cover the eye that appears to be fixing, the straight one. You then watch the other eye, the one you suspect is deviating. If that other eye moves to pick up fixation when the first eye is covered, that confirms a manifest deviation or heterotropia.
Got it. So movement in the uncovered eye means manifest squint. What about the cover-uncover test?
The cover-uncover test focuses on what happens when you remove the cover. You cover one eye for a few seconds, then uncover it, watching only that eye as you remove the cover. If that eye moves to refixate after being uncovered, it means it drifted while covered. This reveals either a latent deviation, heterophoria, that was controlled by fusion, or a manifest deviation if it was already deviated before covering.
Okay, so cover test looks at the other eye. Cover-uncover looks at the same eye as you remove the cover. What's the alternate cover test doing?
The alternate cover test is designed to reveal the total deviation, both manifest and latent combined. You rapidly shift the cover back and forth from one eye to the other, not allowing any time for binocular viewing in between. You watch the eye as the cover is being removed from it, or as the cover lands on the other eye. Any movement seen reveals the full extent of the misalignment when fusion is completely broken.
And the direction of that movement tells you the type of deviation.
Exactly. If the eye moves inwards to fixate when uncovered, It means it was deviated outwards, exodeviation. If it moves outwards to fixate, it means it was deviated inwards, esodeviation. Same logic for vertical movements.
Okay, that clarifies how covering works. Now, how do they actually measure the angle? Quantify it?
The source lists a few ways. The Hirschberg test gives a quick, rough estimate. You shine a pen light at the eyes and observe where the corneal light reflex sits relative to the center of the pupil in the deviating eye.
Centered means straight.
Right. If it's off-center, there's deviation. The source gives rough guides. If the reflex is nasal to the pupil center, it's an exotropia, outward turn. Temporal means esotropia, inward turn. And roughly 1 millimeter of displacement equals about 7 degrees of deviation. Halfway to the pupil margin might be 20 degrees, at the margin maybe 45 degrees. Useful for infants or uncooperative patients.
But for a more precise measure in the clinic,
The prism bar cover test is the most common method described. You use prisms, those wedge-shaped lenses that bend light during the alternate cover test. You hold prisms of increasing strength in front of one eye, base opposite to the direction of deviation, so base out for esotropia, base in for exotropia, until you find the strength that completely neutralizes the refixation movement of the eyes.
so the prism bends the light just enough that the eye doesn't need to move.
Exactly. The strength of the prism that stops the movement equals the angle of the deviation, measured in prism dioptries.
And you mentioned a variation if one eye sees poorly, the Krimsky method.
Yes. If it's hard to see the movement of the poorly sighted eye, you can use the Krimsky method. You hold the light for the patient to fixate with their good eye, and then you place prisms in front of that good eye until the corneal reflex is centered in the poorly sighted eye.
Clever. And the synoptophore instrument.
Right, the synoptophore. It's based on an older device called the amblyoscope. The patient looks into 2 separate tubes, each presenting an image to one eye. The examiner could adjust the angle between these tubes. They measure the deviation by finding the angle at which the patient perceives the images superimposed or aligned. It's also very useful for assessing binocular vision functions, like fusion and stereopsis.
Speaking of binocular vision and movement, how do they specifically check the eye movements themselves and look for restrictions?
They assess the range of movement, first testing each eye alone, moving in all directions, Gauss-ductions, and then both eyes moving together, versions. If a limitation is suspected, especially in incomitant squints, they might do the forced duction test.
That's the one done under anesthesia.
Usually topical anesthesia is enough. The examiner gently grasps the edge of the eye near the cornea with fine forceps and tries to passively rotate the eye in the direction where movement seems limited.
What does that tell them?
If they feel significant resistance, like pulling against a tight band, it suggests some mechanical restriction, maybe a tight or scarred muscle, or fibrous adhesions. That's a positive forced duction test. If the eye moves freely passively, even though the patient can't move it actively, it points towards a nerve palsy or muscle weakness, not a mechanical block.
Got it. Testing the mechanics directly.
Exactly. And there's also the forced generation test, mainly for eyes that seem almost completely immobile in one direction. Again, under topical anesthesia, the examiner holds the eye gently and asks the patient to try and move it in the direction of the paralysis. If the examiner feels a definite tug on the forceps, it means the muscle is receiving nerve signals and is trying to contract, but it's being prevented from moving the eye, likely by a mechanical restriction. If there's no tug, it confirms muscle paralysis.
And testing binocular vision status? How well the eyes could work together?
There are several tests mentioned. Bagolini striated glasses, the Worth 4-dot test, various stereopsis tests like Titmus fly, Randot. These all present slightly different or dissociating stimuli to each eye to see if the brain confused them, if suppression is present, or if any depth perception exists. The synoptophore is also key here, assessing the range over which the patient can fuse images presented at different angles.
Okay, let's circle back to heterophoria, that latent or hidden squint. Define that again for us.
Yeah. Heterophoria is that underlying tendency for the eyes to misalign, but it's normally kept in check by the brain's fusional vergence mechanism. It's essentially the position the eyes would drift to if fusion were suspended. The source notes that a slight tendency to drift outwards, exophoria at rest, is actually very common, so some degree of heterophoria is almost universal. Perfect alignment orthophoria is rare.
And the types are just named by the direction of the tendency.
Yep. Esophoria, inward tendency, exophoria, outward. Hyperphoria, one eye tends to drift higher than the other named by the higher eye. And cyclophoria, a torsional or twisting tendency, which is rare but apparently causes the most discomfort. Horizontal and hyperphorias are the common ones.
Even though it's hidden most of the time, you said it can cause symptoms.
Absolutely. The main symptom is eye strain, or asthenopia. It comes from the constant, often subconscious effort the brain has to exert through the fusion mechanism to keep the eyes aligned against that natural drift.
And bigger phorias cause more strain.
Generally, yes. The source suggests horizontal phorias over about 5-10 prism dioptries, and even slight vertical phorias, hyperphoria, are more likely to cause trouble. The effort needed to overcome a vertical misalignment seems particularly taxing.
When do symptoms typically show up?
They often worsen with fatigue, illness, stress, or prolonged close work. People might become symptomatic later in life, maybe when starting intense schooling or demanding jobs. Classic complaints include things like letters seem to run together when reading, intermittent blurring, likely due to momentary relaxation of fusion, causing brief, maybe unappreciated double vision, and headaches, often frontal or around the eyes.
So, diagnosis relies on breaking that fusion, right, to reveal the hidden tendency.
Exactly. The cover-uncover test we discussed is key. You see the eye drift under the cover and then snap back when fusion is allowed again. But the classic diagnostic tool here is the Maddox rod test.
Right, the one with the line of light. How does that work again?
You use a special lens made of parallel red glass cylinders, the Maddox rod. You put it in front of one eye, usually in a trial frame. In a dim room, the patient looks at a small, bright spot of light. The rod distorts that spot into a line of light perpendicular to the axis of the cylinders in the rod.
So a horizontal rod makes a vertical line.
Correct. Now, one eye sees the spot, the other sees the line. These images are so different the brain can't fuse them. If the eyes are perfectly aligned at rest, orthophoria, the patient sees the vertical line passing right through the spot of light.
And if they have aphoria?
If they have esophoria, inward tendency, the eye with the rod is turned slightly inward relative to the target light. The image of the line falls on the nasal retina, which is perceived temporally. So they see the line displaced to the same side as the eye with the rod. Uncrossed diplopia.
And exophoria, outward tendency.
The line falls on the temporal retina, perceived nasally. So they see the line displaced to the opposite side from the eye with the rod, cross diplopia. By adding prisms until the patient reports the line is going right through the spot, you can precisely measure the amount of the latent deviation. Same principle applies for vertical phorias using a horizontal line.
And the Maddox wing, what's that for?
The Maddox wing test is specifically designed to measure heterophoria at near distance, like for reading. The patient looks through eyepieces at a card inside the instrument. Septa divide the visual field so each eye sees different parts of the card, typically scales and pointers. They report where the pointer seen by one eye appears relative to the scale seen by the other eye, directly indicating the near phoria.
Useful for convergence issues.
Very useful. The source mentions it's great for diagnosing convergence insufficiency, a common condition where exophoria is significantly worse at near than at distance, often causing reading problems. It also notes that the opposite pattern exophoria, worse at distance than near, might hint at a subtle underlying issue, like a mild sixth nerve weakness.
Can they also test the strength of the fusion system, how much effort it can exert?
Yes, using prism Burgess testing. They introduce prisms of increasing strength, base out to test convergence, base in for divergence, base up-down for vertical, while the patient tries to maintain single vision. This measures the limits of their fusional reserves, how much misalignment they can actively overcome. The source gives typical normal values for convergence, divergence, and vertical fusional ranges. The synoptophore can also measure fusional ranges.
So if someone is symptomatic from their heterophoria, how is it managed? Assuming they have the right glasses already.
Right, refractive correction first is key. If symptoms persist, the source outlines a few options. Low degrees often need no treatment if asymptomatic. For symptomatic cases, orthoptic exercises might be tried.
What kind of exercises?
These can involve things like vergence exercises, using prisms, forcing the eyes to converge or diverge against prism resistance, or training on the synoptophore. The aim is to strengthen the fusional reserves. However, the source notes these often provide only temporary benefit, though they can be repeated.
What about putting prisms in the glasses themselves?
That's another option, prescribing relieving prisms. The base of the prism is oriented to optically shift the image towards the deviating eye's position, reducing the effort needed for fusion. For example, base out for esophoria, base in for exophoria. This provides symptom relief.
But there's a downside.
Yeah, the source cautions against it if possible, especially for horizontal phorias. Providing the prism crutch can sometimes allow the underlying phoria to increase over time, necessitating stronger prisms later. It's generally avoided unless necessary. However, for vertical phorias, hyperphoria, exercises are usually ineffective, so incorporating a small vertical prism into the glasses is often the preferred treatment.
And for that common convergence insufficiency, any simple tips?
The source mentions simple home exercises like pencil push-ups. You hold a pencil at arm's length, focus on the tip, and slowly bring it towards your nose, trying hard to keep it single. Stop when it doubles, look away to relax, then repeat. Doing this regularly can help build convergent stamina.
Is surgery ever an option for heterophoria?
Yes, but usually only for large angle, highly symptomatic phorias that haven't responded to other treatments. The procedures are similar to those for manifest squint recession or resection of muscles. The goal isn't necessarily to eliminate the phoria completely, but to reduce it enough so the patient's own fusion can handle the remainder comfortably without causing eye strain.
Okay, now let's switch gears fully to managing the manifest squints, the heterotropias. Let's start with convergent strabismus, deviation.
Right, as we said, common in hypermetropic kids. The source mentions classifying them based on etiology, like non-accommodative, accommodative, which can be refractive due to hypermetropia, or non-refractive due to a high ACA ratio, or mixed types. But the general management sequence in children often follows three main steps: refraction, occlusion, and then potentially operation.
Walk us through that sequence in practice.
Okay, step 1, refraction. Get an accurate glasses prescription, usually with cycloplegic drops like atropine. Do that careful fundus exam to rule out nasty surprises. If significant hypermetropia is found, prescribe the full correction, especially any astigmatism. Have the child wear the glasses constantly, then re-examine after about a month.
My God, the re-examination.
Because sometimes, especially in purely refractive accommodative esotropia, just wearing the correct glasses fully corrects the squint. If the squint is gone or significantly reduced with glasses, surgery might not be needed or might be delayed. The source also mentions specific cases, like using bifocals for kids with non-refractive accommodative esotropia, the high ACA ratio type, where they overconverge mainly at near.
Any alternatives to glasses?
Miotics, like anticholinesterase drops, are mentioned as an alternative for very young children or those who absolutely won't wear glasses. They work by stimulating the accommodation, reducing the effort needed, thus reducing convergence. But the source notes side effects and says they aren't very popular now.
Okay, so glasses first. What if the eye is still turned insignificantly with the glasses? And what if one eye sees poorly?
That brings us to step 2, occlusion. This is the primary treatment for any amblyopia lazy eye present, which is very common with constant unilateral esotropia. The goal is to force the brain to use the weaker amblyopic eye.
By patching the good eye.
Exactly, usually with an adhesive patch worn directly on the skin. The source stresses it needs to be total occlusion for it to work, no peeking.
Why total?
Because if the good eye can still get any visual input, the brain's established habit of preferring it and suppressing the other eye will likely continue, hindering visual recovery in the amblyopic eye.
Is patching the good eye risky?
In young children, yes. There's a risk of causing occlusion amblyopia in the good eye if it's covered for too long without breaks. The source describes regimens like patching the good eye for several days, then patching the amblyopic eye for 1 day, adjusting the ratio based on the child's age and response. Careful monitoring is essential. After age 8 or so, the risk to the good eye is much lower.
Does patching help the squint angle itself?
Not directly. Its main purpose is to treat the amblyopia. Improving vision in the squinting eye can sometimes improve motor control, but the primary goal is visual rehabilitation.
What about orthoptic training? Where does that fit in?
Orthoptic training uses exercises, often with instruments like the Synopta 4, to try and encourage binocular vision, simultaneous perception, fusion, stereopsis. It's not about strengthening muscles. The source says it can be effective for small-angle squints, intermittent squints, or as an adjunct before or after surgery.
But not usually a cure on its own for larger squints.
Generally not for constant squints over about 10-15 degrees, or long-standing ones where suppression is deep. It's most valuable preoperatively to try and develop some binocular potential, reduce abnormal correspondence, and postoperatively to consolidate surgical results and improve fusion ranges. It requires patient cooperation and needs to be systematic. If there's no improvement after a few months, it's usually discontinued, except maybe in accommodative cases.
Okay, so if glasses and amblyopia treatment aren't enough and orthoptics aren't the primary solution, that leads to step 3, operation.
Yes, surgical treatment. Indications are typically a residual convergent angle of 10-15 degrees or more while wearing the full glasses correction, especially if binocular potential exists or for cosmetic reasons.
And timing is crucial, right? You mentioned early surgery.
Hugely important, yes.
Yeah.
The source strongly advocates for surgery between ages 4 and 5 if possible, but ideally even earlier within the first 18-24 months of life if the goal is to achieve good, functional binocular vision.
Why so early?
Because the chances of developing proper fusion and stereopsis decrease significantly the longer the eyes remain misaligned during that critical developmental period. If surgery is delayed until, say, age 10 or older, amblyopia is often irreversible, abnormal correspondence might be fixed, and the surgery is often purely for cosmetic improvement. You miss the window for functional cure.
What are the standard operations for esotropia?
Usually involves weakening the medial rectus muscle, which pulls the eye in, via recession, and/or strengthening the lateral rectus muscle, which pulls the eye out, via resection. Often, surgery is performed on both eyes, especially for larger angles, to achieve a more balanced result. The source cautions against outdated procedures like free tenotomy and mentions specific limits for recession, like max 5 millimeters on a medial rectus, to avoid compromising convergence later.
And what about alternating squints, where either eye can turn in?
If it's an alternating esotropia picked up late in childhood, treatment is usually just cosmetic surgery if the angle is large. But, and this is a key takeaway, if an alternating squint is seen very early, under age 2 or right after onset, there is a good chance of achieving a functional result with binocular vision after surgery.
Which again hammers home the need for early referral.
Absolutely. Any infant suspected of having any type of squint needs prompt evaluation by someone experienced.
Okay, shifting to divergent strabismus, exodeviation. The source says management principles are similar.
Yes, the overall approach follows the same logic. Correct any significant refractive error first, especially myopia here. Manage any amblyopia, though it's less common and often milder in exotropia than esotropia. Consider orthoptics for smaller intermittent deviations, and then surgery for larger or constant deviations.
Any specific classifications for exotropia?
The source mentions Duane's classification from way back in 1896, which is still useful. It categorizes exodeviations based on whether the divergence is worse at distance, divergence excess, worse at near, convergence insufficiency, though often considered a separate entity, or about the same basic type. This helps tailor treatment.
And the surgery for exotropia?
It typically involves weakening the lateral rectus muscle, which pulls the eye out, via recession, and/or strengthening the medial rectus muscle, which pulls the eye in, via resection, often a combination on one or both eyes.
Any differences in surgical goals compared to esotropia?
One key point the source makes is that exotropia has a tendency to recur or drift outwards again over time after surgery. Because of this, surgeons often aim for a slight initial overcorrection, leaving the eyes looking very slightly turned and immediately post-op in the hope that as things settle, they'll end up straight.
And postoperative double vision can be an issue here too.
Yes, temporary diplopia can occur after straightening in exotropia, especially in adults who might have adapted to the outward turn. It's usually manageable and resolves.
The source also dedicates space to A and V patterns. What are those again?
This is when the amount of horizontal misalignment changes significantly depending on whether the person is looking upwards or downwards. In a V pattern, the eyes are more converged or less diverged in down gaze, and more diverged or less converged in up gaze, forming a V shape. A pattern is the opposite, more converged in up gaze, more diverged in down gaze.
How are they assessed?
By measuring the deviation with the cover test, not just in primary position, straight ahead, but also specifically in about 25 degrees of up gaze and 25 degrees of down gaze.
And when do these patterns need specific surgical treatment?
If surgery is purely for cosmetic reasons, small patterns might be ignored. But surgery specifically targeting the A or V pattern is indicated if the patient has binocular vision and fusion in some field of gaze, but has to adopt a compensatory head posture, like chin up or chin down, to maintain it. The goal is usually to improve alignment in primary and downward gaze, which are functionally more important.
What causes these patterns? Which muscles are involved?
The oblique muscles are thought to play a major role, more so than the vertical recti. Overaction of the inferior obliques or weakness of the superior obliques tends to cause a V pattern. Conversely, overaction of the superior obliques or weakness of the inferior obliques tends to cause an A pattern.
So surgery involves the obliques or repositioning the horizontal muscles.
Exactly. If there's clear oblique muscle overaction, surgery might involve weakening the overacting oblique. If the obliques seem okay, the source describes procedures that vertically shift the insertions of the horizontal rectus muscles. The rule of thumb is to move the medial recti towards the closed end of the pattern, down for V, up for A, and the lateral recti towards the open end, up for V, down for A. There are specific procedures outlined for combining these with horizontal adjustments.
Okay, one more specific type mentioned, microtropia. Sounds small but tricky.
Yes, microtropia is defined as a very small angle manifest esotropy, usually less than 10 prism dioptries, about 5 degrees. It's often associated with mild or moderate amblyopia, eccentric fixation, and that harmonious abnormal retinal correspondence, ARC.
Why is it hard to spot?
Because the angle is so small, it's often cosmetically unnoticeable. And the presence of eccentric fixation means the standard cover test might not show any movement or only a tiny flick because the eye is already using a non-foveal point for fixation.
So how do they detect it, the 4-prism dioptry test?
That's the key test described. You place a 4-prism diopter prism, base out, in front of the suspected good eye. Normally, this would cause that eye to move in, adduct, and the other eye to make an equal outward movement, abduct, followed by a small inward fusional recovery movement. In microtropia, the deviating eye makes the outward movement but lacks the subsequent inward fusional recovery movement.
And what happens if you put the prism in front of the squinting eye?
If you place the 4PD base-out prism before the microtropic eye, the prism shifts the image onto the central suppression scotoma associated with the eccentric fixation. Because the image lands on this non-seeing area, neither eye makes any movement. This response, or lack thereof, helps confirm the diagnosis.
What causes microtropia? And what symptoms might someone have?
The exact cause is uncertain, but the source notes anisometropia, unequal refractive error, is common. Often there are no symptoms, and is picked up incidentally when slight amblyopia is found on vision screening. Some individuals might report vague reading difficulties, possibly related to the crowding phenomenon or awareness of the central scotoma.
And treatment?
The source is quite blunt here, stating there's nothing specific to offer by way of treatment for the microtropia itself. Management focuses solely on treating the associated amblyopia with occlusion, if present and deemed treatable.
Okay, let's get practical for a moment and talk about the actual operations on the eye muscles. The source gives some context.
Yeah, it notes that the eye's position under general anesthesia doesn't necessarily predict the final outcome. Surgeons have to rely on their careful preoperative measurements. Asepsis, sterility, is obviously crucial. And interestingly, post-op eye padding isn't usually needed anymore.
Adjustable sutures were mentioned. When are they used?
They can enhance results in more complex or unpredictable cases, like reoperations or squints caused by thyroid eye disease. The suture securing the muscle is tied in a temporary bow knot, allowing the surgeon to fine-tune the muscle's position slightly the day after surgery, once the patient is awake and cooperative, before tying a permanent knot.
You already explained the basics of recession, weakening by moving insertion back, and resection, strengthening by shortening the muscle. What other types of procedures are done?
Well, for the oblique muscles, there are various weakening procedures. For an overacting inferior oblique, common in V patterns, options include recession, myectomy, cutting out a piece, or anteropositioning, moving its insertion forward near the inferior rectus, effectively weakening it. For the superior oblique tendon, involved in A patterns or Brown syndrome, weakening usually involves tenectomy, cutting out a section of the tendon.
What about strengthening obliques?
Strengthening the superior oblique might be done for torsional problems after a fourth nerve palsy, often by selectively advancing part of its insertion.
Any other techniques mentioned for the rectus muscles?
Yes. Marginal myotomy involves making partial thickness cuts across the muscle belly to weaken it without detaching the insertion, sometimes used if a muscle is already maximally recessed. Muscle transposition procedures involve rerouting parts of healthy muscles to take over the function of a paralyzed muscle. The source mentions the Jensen procedure for a complete lateral rectus palsy, where slips of the superior and inferior recti are attached to the lateral rectus.
And the Faden operation, that sounded different.
The Faden operation, or posterior fixation suture, is interesting. The suture is placed attaching the muscle belly to the sclera, the white of the eye, far behind its insertion, maybe 12-18 millimeter back. This doesn't change the eye's position much when looking straight ahead, but it changes the muscle's leverage or arc of contact with the globe. It specifically weakens the muscle's action only when the eye rotates into that muscle's main field of action. Useful for certain types of incomitant squints or convergence excess.
Lastly, conjunctival recession and hangback sutures.
These are often used in cases with mechanical restrictions, maybe from scar tissue after trauma or previous surgery. Sometimes the conjunctiva itself becomes tight and needs to be recessed, moved back. Hangback sutures are a technique, often for medial rectus recession, where the sutures attaching the muscle are tied to the original insertion site but left long, allowing the muscle to effectively slide further back on the globe than the measured recession amount, useful for large recessions needed in restrictive cases.
Okay, like any surgery, squint surgery has potential complications. What does the source list?
During the operation itself, risks include the ocular cardiac reflex, that slowing of the heart rate when pulling on muscles, especially the medial rectus. A muscle could potentially slip from the forceps and retract back into the orbit, becoming lost, which is a serious issue. And very rarely, accidental perforation of the sclera with a needle could occur.
And complications that might show up afterwards.
The most common are alignment issues, overcorrection, resulting in a consecutive squint in the opposite direction, or undercorrection, a residual squint. Others include chronic redness or inflammation, excessive scar tissue, granuloma formation, small inflammatory bumps, and rarely anterior segment ischemia, reduced blood flow to the front of the eye. Diplopia, as we mentioned, can occur post-operatively, sometimes temporarily. And like any surgery, there's a small risk of serious infection, either inside the eye, endophthalmitis, or around the eye, orbital cellulitis.
Right. So we've really journeyed through the complex world of strabismus, focusing specifically on the comitant type, drawing heavily on this detailed medical text.
Yeah, and it's clear that squint is far more than just a cosmetic issue, isn't it? It's fundamentally about a breakdown in the intricate system required for binocular vision, often with roots in early visual development.
We've explored the various contributory factors from refractive errors and muscle imbalances to that crucial link between focusing and convergence. And we've seen how the brain remarkably adapts through suppression, but how that adaptation can lead to amblyopia and even rewire retinal correspondence.
And we've really dug into the diagnostic process, from the cornerstone cover test and prism measurements to specialized instruments like the synoptophore, all aimed at precisely characterizing the misalignment. Then we outlined the spectrum of management.
Right, from the essentials of glasses and amblyopia treatment with patching, through orthoptic exercises, and finally detailing the principles behind various surgical procedures on the eye muscles themselves, recessing, resecting, transposing.
It definitely underscores the delicate balance involved between vision, muscle mechanics, and brain processing. And it really hammers home why early detection and intervention, particularly in children, are so absolutely vital, not just for achieving straight-looking eyes, but for maximizing the potential for functional stereoscopic binocular vision.
It does, and considering how profoundly the brain can adapt to misalignment through these mechanisms like suppression and eccentric fixation, it does make you think, doesn't it? What does this incredible adaptability tell us about the brain's general plasticity, but also perhaps its inherent limitations when faced with flawed sensory input during those critical early windows?